We're going to call Dr. Chauhan up to do our first presentation. Thank you so much. So, this is actually going forward. That's going backward.
Perfect. Thank you. And the pointer works?
Oh,
awesome.
Yeah.
Great. Hello. Good morning, everyone. Okay. I recently shaved, so I look like a medical student. But trust me, I've been doing this for many years now. All right. My name is Chauhan. I'm one of the assistant professors of medicine at University of Kentucky, and I direct our PRRT program at University of Kentucky Markey Cancer Center. Yes.
Can you raise that microphone?
Oh, sure. Better? Okay, perfect. And I happen to be trained by some of the net gurus. Very fortunate. Dr. Wang is here. He was my mentor during residency. And then he asked me to get trained with Dr. Lowell Anthony in Lexington, Kentucky. So he trained me for 3 years in neuroendocrine tumor-specific disease. And now I'm on my own. So, all right. What I'd be talking about today is a very general concept overview of what neuroendocrine tumors are. It's a complex disease, so I try to simplify as much as possible. Some disclosures. We have some research grants from industry and NIH. My talk for today would be focused on your low-grade, typical, well-differentiated neuroendocrine tumors, otherwise in past used to be called carcinoids. I would avoid talking about other types of or rare subsets of neuroendocrine cancers, pheochromocytomas, high-grade small cell or large cell neuroendocrine carcinomas, because of the time we have. The talk would be divided on what's the current epidemiology, what's the burden of this disease, then a little bit about the biology of disease, pathology, how do we go about diagnosing this disease, how do patients present, how do we treat them. So, just a brief primer. Neuroendocrine tumors are rare tumors. It can happen anywhere in the body because these cells which develop neuroendocrine tumors are present throughout the body. I've seen neuroendocrine tumor of breast, rectum, stomach, pancreas, you name it. So the primary neuroendocrine tumor can actually happen from any part of the body. The incidence of neuroendocrine tumor, and the word incidence, it's a rate. What it means is how many new cases per year of that particular disease. It's quite low as compared to some of our common cancers like colon cancer or breast cancer. However, it's been changing, and I'll kind of discuss that in a minute. The prevalence of the disease, which means what's the overall burden of the patients, not new cases per year, but how many total patients with that particular diagnosis present in any particular time, that's called prevalence. The prevalence of the disease is hugely disproportionate to the incidence. And the reason for that is, like Marianne said, fortunately, most of our neuroendocrine tumor patients, they live for many, many years. So every new diagnosis keep accumulating. The burden of the disease is far overwhelming as compared to incidence of the disease. Now, neuroendocrine tumors come in various flavors. It has low-grade, intermediate-grade, high-grade. Functional neuroendocrine tumors, the ones which secrete hormones, be it gastrinoma, VIPoma, serotonin, or non-functional. All of these leads to complexities in terms of how they manifest or present and what are the challenges we face. So very heterogeneous tumors. And just like Marianne said, kind of like zebra stripes, every neuroendocrine patient is very different. They can both have grade 1 neuroendocrine tumor, but completely different way they present it, or they're going to metastasize or progress or not progress. So can't really You have to study each patient on its own. Okay, first few slides are on the current incidence and epidemiology of this disease. If you look at the 1970s, about 5 decades back, we used to diagnose 1 in 100,000 people. Very low incidence and fits the definition of a rare tumor. Fast forwarding, in 2012, that's the most latest data we have on this year, the incidence has increased 7-fold, while the blue line, which is the incidence of common cancers like breast cancer, lung cancer, colon cancers, plateaued. So why is that? Why has the incidence of neuroendocrine tumors shot 7-fold? Well, we don't really know the exact answer, honestly. I think a big part of it is that we are definitely getting better in diagnosing these tumors. There's more awareness as compared to 40 years back, where people would not even know about this condition or acknowledge this. Fortunately, today, a lot more people know about what neuroendocrine tumors are. A lot more people are getting colonoscopies, endoscopies, scans. So, we are diagnosing quite a bit of disease. However, does that explain all the rise or the hike in incidence? I'm not sure. I am cautiously, I do think that there is an environmental factor to it. However, we need to study. And if this incidence rate continues to keep increasing at this pace, we'll be kind of obligated to figure out what's going on. Can't be just all improved diagnostics. Last year, we studied our own Kentucky Cancer Registry database. So every state usually have a cancer registry. So every new diagnosis of cancer is mandated by law to be registered in the state. We have about 30 nodal registries in the country. So KCR, Kentucky Cancer Registry, one of those 30 nodal registries. And they are assigned as nodal centers because of the infrastructure and the quality of data they have in terms of the incidence reporting. And what we found, our incidence in Kentucky is even higher than the national averages. Our incidence was found to be 10 per 100,000 cases. The blue line is KCR, and the red line is the national average. And the current incidence 2012 was 10 per 100,000. So there's definitely something happening here, and we got to keep a close eye on how the incidences move forward in the next decade. And if it continues to shoot up at this rate, I think this warrants further research. Why is it happening? Is it something in our environment, something we are eating, something we are getting exposed to? We don't know. So increasing incidence of these rare neoplasms mandates us to raise awareness among our colleagues in the medical fraternity industry so that we can develop new treatments, because we are no longer 1 in 100,000 disease. We are seeing a lot more of these neuroendocrine tumor patients in our primary care setting, in the specialty setting, etc. All right. Moving on from the epidemiology and the burden of disease, let's talk a little bit about the pathology. Pathology is the key here. I'm a clinician, I'm a medical oncologist, but the most vital piece of information when I see a patient for the first time is the pathology. We cannot institute a proper plan for treatment if I do not know what the pathology is. So it's really critical. Unlike some tumor type, as long as I know this is this particular type of lung cancer, squamous cell lung cancer, I know what exactly to do. Neuroendocrine tumors are way more nuanced than that. I really need to know, is it a grade 1 tumor, grade 2 tumor? Is it a grade 3 tumor? If it's a grade 3 tumor, is it a well-differentiated or a poorly differentiated grade 3? where is the tumor coming from? Is it a pancreatic neuroendocrine tumor, or is it a rectal neuroendocrine tumor? So a lot of nuances to it. This slide shows how a neuroendocrine tumor, the well-differentiated, the carcinoids or the low-grade, look under the microscope. One of the terminologies you all probably have heard during the course of your treatment and diagnosis, Ki-67. That's one of the stains we use, this blue slide in the middle. That's one of the stains we use to stain these tumor cells and to kind of see how fast they are dividing. The faster they're dividing, the higher Ki-67 stain they take up. That means they are higher grade. This slide is a high-grade neuroendocrine carcinoma. There are two variants of it. One's called small cell, other one's called poorly differentiated. And the middle, the similar Ki-67, it's taking up a lot more stain this time, right? It's almost all brown as compared to this one hardly taking up any stain. So what that means is this is a more aggressive variety of neuroendocrine neoplasms, right? So WHO came up with a classification. In 2010, they used to divide neuroendocrine tumor into 3 types: grade 1, grade 2, grade 3. And this was based on cutoffs, Ki-67 up to 2% grade 1, 2 to 20 grade 2, more than 20 grade 3. This did, for the first time, give us some guidance how to treat, because I want to be more aggressive with the grade 3 because it's an aggressive disease. However, grade 1, I have a little bit more time. I rather treat them with options which are gentler and mild, and not use more toxic treatment till it's absolutely needed. So this information does help me find out what specific systemic therapy should I use in what fashion. However, a couple of years back, WHO did recognize that there was need to further learn more about the grade 3 neuroendocrine tumors, because not all grade 3 neuroendocrine tumors behaved the same way. They initially had clubbed this Ki-67 more than 20 into one big group. But more than 20 can mean 50, 70, 90. Do they all behave the same? So there was a lot more data. You know, the line in the black, that's the disease-specific survival for low-grade or the carcinoids or the low-grade neuroendocrine tumors. And we know that most of our low-grade neuroendocrine tumors do well, and the survival in terms of many years and decades, right? We are going 200, 250 months. However, this particular group, the one in the red and the blue, they're all high grade, grade 3. But within the grade 3, there are 2 distinct groups. One are bad biology, the one in the red line, and the one is somewhat better as compared to the red line. And now we know, even within the grade 3, the well-differentiated grade 3 does better than the poorly differentiated grade 3. So the blue line suggests well-differentiated grade 3 neuroendocrine tumor versus the red line. And this is really important because not just the survival patterns, the way they are treated, chemotherapy, the type of chemotherapy, type of scans we do on them, does change. So based on these new findings, 2017 WHO again revised their classification, and now we have 2 types of grade 3 neuroendocrine tumors. One is a well-differentiated, other one's a poorly differentiated. In past, there used to be all poorly differentiated. So you can see we have made improvements not in terms of learning the burden of the disease. We are studying the incidence and prevalence constantly, but even the way we diagnose and classify this disease, there's been a lot of changes in just very recent years. So there's a lot of new things coming up. You guys feel like drowning in information? That's the kind of stuff I used to hate in med school, the epidemiology and pathology, you know. But you know, sorry about that. It is very important though. And this slide would kind of summarize why it's important to know the biology or pathology of the disease. See, on this end of the spectrum is well differentiated, or your carcinoids, and at this end of spectrum is your high grades. The way we scan them, net spot versus FDG PET, very different. The way we treat them, sandostatin, lanreotide, Afinitor versus carboplatin, etoposide, irinotecan, very different. So if we don't know what we are dealing with, I can't do a proper test, I can't do a proper scan, have a proper follow-up schedule. These patients I would probably scan every 2 months because they are aggressive. These patients, based on individual patient, can go up to every 3-6 months. Some patients I scan once a year. It depends on that particular patient and their biology. Okay. Quick word on neuroendocrine tumor specific biology. So these tumors are a little unique as compared to lung cancer, prostate cancer, or breast cancer in the sense that they have what's called somatostatin receptor on their surface. These tiny little red dots you see, these are different types of somatostatin receptor, 1, 2, 3, 4. And we've really used this knowledge not just to help us diagnose these cancers better, but also in terms of therapy. So how many of y'all are currently on analogs, sandostatin or lanreotide? Right, good. So these two specific drugs are what's called somatostatin analogs. That means they love these receptors. So if they find a receptor, they bind to it. So whenever you get the shot, the somatostatin analog is in your blood. It tries to find the neuroendocrine tumors because it has a particular affinity to these particular receptors. Once it binds to them, what happens? From the studies we know, it helps slow the tumor down. And it also helps slow the release of some of these hormones in certain patients, like serotonin. So it less the amount of hormone secreted, the syndrome goes away, or it's somewhat better controlled, right? So that would have been possible because we know the biology of disease, that these receptors exist, and we found a compound which works on them. Taking it to a step further, how many of you all know about PRRT, or peptide receptor radiotherapy? Good. So that's a similar kind of drug where the somatostatin analog is carrying is carrying on its back a radiation molecule. Okay. Now the somatostatin analog loves these somatostatin receptors. We inject it in the IV, goes into the blood, it's trying to find the tumor with somatostatin receptors, right? And as soon as it finds it, it joins them because it loves them. And it's carrying this nuclear payload with it, right? As soon as it finds it, joins it, and it radiates it. And we now know that that particular therapy works very well in these neuroendocrine tumor patients who have these receptors. So see the amount of advancement we could do in a disease type if we really know what's happening at the cellular level and use this information for our benefit so that we can diagnose these patients better and treat them better. Similarly, over the past 10 years, we've learned further mechanisms, how these tumor cells grow, why they grow, how did they break up from the primary site and goes and like settle in liver, what are these mechanisms, why do they metastasize, or so one of the pathways which kind of comes up again and again related to neuroendocrine tumors called mTOR pathway, and has been researched extensively. And the product, the outcome of all that research culminated into the fantastic therapy we have today, the Afinitor. Okay, how many of you all have been on a Afinitor? Okay, so Afinitor is a pill form of therapy. It's a targeted therapy, which is an mTOR inhibitor. And in past 10, 15 years, we've seen various clinical trials in form of radiant studies where this drug has been studied, and now it's FDA approved for GI and thoracic neuroendocrine tumors and pancreatic neuroendocrine tumors because it really works. We'll talk a little bit about it in the next few slides. So that was all old news. What's the latest and the greatest in learning the biology of neuroendocrine tumors? So lately, I'm sure you guys have heard about personalized medicines or precision medicine, right? So what we are learning is that everybody's tumor is somewhat different, okay? And that's because of the kind of mutations the DNA of that tumor has. It's very specific or different to that individual patient. We are leveraging that information to really treat that particular patient differently in a lot of other tumor types. For example, lung cancer or breast cancer. You know, there used to be an entity called triple-negative breast cancer, still is. But within triple-negative breast cancer, now because of the gene next-gen sequencing and studying their genetic mutation, we know there are different subtypes, and some needs to be treated more aggressively than the others. So we are finally catching on that next-gen sequencing of the DNA for neuroendocrine tumor type. A part of it was, the effort was, I think, led by Memorial Sloan Kettering, but a lot of us now are sequencing our patients on a more routine basis. For example, at least at Market, my center, we sequence all our neuroendocrine tumor patients, and this is done under the research protocol because some of these tests can be really expensive, costing $4,000 or $5,000. So this is done under the research protocol with the research funding, so that it doesn't impact our patients. And as of now, however, we are not using that information to make clinical decision, but all that wealth of information in near future would help us guide what particular mutations make one person susceptible to particular treatment or increase sensitivity or decrease sensitivity or resistant patterns, etc. So that's definitely the frontier. What I would briefly mention, however, when we sequence somebody, we take the part of biopsy tissue, send it to the lab, they take the DNA out of it. Then they have these fancy machines where they run scans to study their genetic mutations and what particular mutation, and there are hundreds of mutations, but they look into the ones which are more relevant and happen often in the neuroendocrine tumor. And this is a screenshot of some of these mutations that we might be seeing in neuroendocrine tumors. And what I would like to point out is the mutation patterns are very different when it comes to high-grade, poorly differentiated neuroendocrine cancer versus high-grade, well-differentiated versus the rest of it. From some of the early publications, we now know that some of these mutations can help predict who's going to do better than the others. For example, if the pancreatic neuroendocrine tumor patient harbors DAX or ATRX mutation, they do a lot better as compared to if they were wild type, that means no mutation, they do worse than patients who actually had these two mutations. On the contrary, if patient has a mutation which is often seen in melanoma called BRAF mutation, if somebody has that particular mutation, they often do pretty bad as compared to if they did not have that mutation. So we are learning a lot more new things about neuroendocrine tumors and tumor genetics. This is not ready for prime time yet, but I suspect in the next 5 years, we'll have a lot more data from various centers validating these findings and incorporating these into our clinical practices, okay? So I spoke to Dr. Tang a couple of years back. She is a very world-renowned pathologist from Memorial Sloan Kettering and specializes in neuroendocrine tumor. And she candidly told me that she expects some of these genetic findings or subtyping to be a part of actual WHO classification in near future. So next time the WHO updates, might be 2020, it might actually be a part of diagnostic, where we'll have to mandate doing next-gen sequencing all these patients. The more information we have, the better we are prepared to know what to expect and how aggressive to be. So a lot more happening in this area as well. Just to kind of summarize that whole genomics, I recently got a small grant to study this particular thing, especially for high-grade neuroendocrine carcinoma, as I showed that there are two different distinct subtypes of these high grades. How do we currently treat the high-grade neuroendocrine carcinoma? Not very smartly. We all give them the same type of chemotherapy drugs. But what if we knew that these are two subtypes, very different? If we knew that information up front, would treating them differently help? And that's what we are trying to currently study with this particular trial. Okay, moving on. How do we diagnose these cancers? So we've done the whole basic science and the science and biology part of neuroendocrine tumors. How do we go about diagnosing it? And then that is somewhat a challenge, because the way neuroendocrine tumor present, at least for the majority of patients, the symptoms are very vague. Patients can present with flushing. Patient can present with wheezing. Patient can be completely asymptomatic, normal. Patient can present with weight loss. And all these symptoms are also seen in non-cancerous conditions: asthma, hormonal changes, irritable bowel syndrome, food allergies. So when a primary care doctor sees somebody with these vague symptoms, they often tend to not think about neuroendocrine tumors, unfortunately. I have a small experience in this space from our own practice itself. When I was at LSU doing my training, we were looking at a very particular subset of lung neuroendocrine tumor called DIPNISH, diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. And what we found, I studied 5 cases, we later published it in Lung. All these 5 cases were delayed diagnoses for good 5 to 7 years. They were misdiagnosed as asthmatics, they were treated with bronchodilators, they were misdiagnosed with allergies, misdiagnosed with COPD, and whatnot. So this is a real phenomena. So part of it is just picking up and being smart enough about picking up these symptoms and teasing it out to an actual diagnosis. And the other challenge occurs even when these patients are diagnosed, or at least in in recent past, even when they were diagnosed, there was a discordance between pathologists in diagnosing them. And there's a very well-published phenomena where the two pathologists would not agree that this is a particular type of neuroendocrine tumors. I think this is a problem of past. Hopefully, it's not a current issue, but this is well published. Some of these publications are actually quite recent, 2016. So the similar case, when assigned to various pathologists, people had different opinions. Somebody typed it as grade 2 neuroendocrine tumor. Somebody suggested this is grade 3, well differentiated. So even when we are able to diagnose them, it's really critical for patients to see a neuroendocrine group which has a specialized pathologist and specialized physician who deal and see these patients more often, because people can get confused with these rare tumors. All right. Fortunately, we are improving in terms of the tests we have in our arsenal to help make these diagnoses. Some of the blood tests, I'm sure you all probably have heard about: chromogranin, serotonin, 5-HIAA, pancreastatin. There's a whole slew of panel based on what symptoms patient has. The physician tries to do an appropriate test. If I feel that this patient has a clinical symptomatology fits with gastrinoma, I'll check a gastrin level. I don't always have to do a 15, 20 chemical panel on every patient. That's why history taking, listening to the patient, and a thorough exam is very important to really direct our workup. Okay? Although these tests are helpful in diagnosing and monitoring the patient, unfortunately, they are not the most sensitive and specific tests. What that means is that one fine day, your blood chromogranin can be really high, and the other visit could be low. So you have to take it with a grain of salt. Okay? These tests are never confirmatory. You always have to have a biopsy-proven diagnosis, but they help us make the supportive case. Overall, how are we doing? Is our chromogranin trending down with the treatment, or is it still rising down the road? But one of the big leaps we have made in the recent past, oh, I'm good, thank you, is in terms of our scanning. And I think this development was pretty impressive. So in past, we used to do a test called octreoscan. It's a functional neuroendocrine tumor scans, which uses this capability to detect the somatostatin receptor. Now we have a scan which is basically octreoscan on steroids called NetSpot. This scan was FDA approved in 2016, and you can compare the pictures, same patients with octreoscan and NetSpot, otherwise called gallium dotatate scan. Which one's better? Now look at the precision with I can see individual tumors within the liver and outside liver, which were otherwise completely missed. Now I don't want to advocate with one technology versus the other, but clearly I cringe when I see a patient with still getting octreoscan. I think clearly when we have a better technology, and it helps me big time to kind of make a better and more informed management plan with a better scan. It does help. So I'm very happy about this development. NetSpots are 90% sensitive and specific in terms of diagnosing neuroendocrine tumors. Can detect even a small 4 millimeter lesion, 3 millimeter lesion. So it's FDA approved. And we recently discussed our data at GI ASCO in January in San Francisco, where we reviewed 200 of NetSpot patients. And what we found, NetSpot not only helps us diagnosing unknown primary when we previously didn't know where the tumor was coming from. All we saw was metastatic disease in liver, bone, or wherever. It also helps us find out the primary tumor. It's able to pick up small primary in the small bowel or pancreas, which were otherwise labeled as unknown primary. It helps us tease out the biology of disease. So the median SUVs, that's how hot the lesion look on the NetSpot, that reduces as the grade of tumor increases, And at least in our center, we are using NetSpot to also direct our local regional therapy. So you've heard about embolization of the liver mets. We are using NetSpot, which is a functional scan, to direct which lesion needs to go first. The harder the lesion, we are trying to go towards them first. And the data for doing that is still maturing, so I can't say that that's the right approach. But so far, anecdotally, we have had good experience with that. So very, very, very good technology. We definitely love it. That's our neuroendocrine tumor program at Markey Cancer Center. As you can see, gallium scan plays a pivotal role. It's the first step before we even present the case to our tumor board and then discuss surgery versus interventional therapy versus medical oncology. So a big leap in terms of how we diagnose these patients in recent past. All right, now the last leg of my talk. So we talked about advancement or growth in our knowledge in terms of disease burden, in terms of pathology and biology, and now diagnostics. Now the last frontier is treatment. All this, is it culminating into better treatments for our patient? Or is it still, like Marianne said, we had one drug when she was first diagnosed? Fortunately, that's not the case any longer. I feel very lucky to be practicing neuroendocrine oncology in a time period where our treatment options are growing, and there are a lot more treatment options currently being evaluated in pipeline. So this is, I think, by far the most exciting period to be in this area. So I would summarize some of the key practice-changing studies and not so much of the experimental stuff at the beginning. Okay, so cancer treatment, the three pillars of cancer treatment are traditionally surgery, radiation, chemotherapy. Okay? What's the role for surgery? I don't want to take thunder away from Dr. Wang's talk. He is a master surgeon, and his talks are brilliant. But I will mention that for early stage disease, stage 1, stage 2, stage 3, clear indication we should try to resect as long as patient is fit enough for surgery, because you can really aim for cure or long-term disease-free survival in these patients. However, the debate is still on for metastatic disease. If you already have stage 4 disease with liver mets, is there a role for surgery? And there are people in both the camps who like surgery, who don't like surgery. I'm a little biased towards, I'm a pro-surgery guy because I was kind of trained by Dr. Wang and Dr. Woltering and Dr. Boudreau and such. But one way to evaluate that question is a randomized trial, which unfortunately we cannot do. It's unethical to flip a coin and say, hey, you get surgery and you don't get surgery, right? So we are in this catch-21 situation where we would never generate that really unbiased data. However, I will mention when I was a resident with Dr. Wang, we analyzed our data close to 300, 400 patients. And in our data set, people who did get debulking surgeries lived significantly longer, 236 months versus 148 months. However, you have to understand that this is not a randomized data set. People who did not get surgery could be sicker to begin with, and that's why they didn't survive that long. However, in a right setting, in the right hands, with the right surgeon, I personally feel that there is definitely a role for surgery in metastatic setting as well. The current therapeutic landscape of how we treat these neuroendocrine tumors is constantly evolving. We are adding new drugs. And this slide's from 2012. And since this slide, we have now many more drugs currently FDA approved and in pipeline. One of the biggest or the backbone of our systemic therapy is mTOR inhibitor or Afinitor. And it's been extensively studied in many, many patients. Over 13,000 patients have been studied so far. And what we found most recently in RADIANT-4, which was a large international phase 3 clinical trial, patients who got Afinitor, the one in the blue line, were able to keep their disease stable for about a year, as compared to patients who were on placebo. Of course, the median PFS was 3.9 months. So clearly the drug is active in neuroendocrine tumors. And based on this data, FDA approved it for all sites, lung, pancreas, GI tract, for management of progressive neuroendocrine tumors. In my practice, I use it once patients progress on analogs, sandostatin, lanreotide. That's my next go-to drug. However, things are not as simple now, with especially the approval of PRRT and data on CAPE-TAM. we have a lot more options, and it's not a very straightforward cookbook decision what's the next therapy. The next drug I'll briefly mention is telitrestat. This is a really good drug, and first in its class, which focused on actually symptom management of our neuroendocrine tumor patient. All the other drugs prior to that were mostly looking at, well, sandostatin was also in the similar area where it was studied to reduce diarrhea first. But the FDA approval for telitrestat is specifically for diarrhea control in carcinoid syndrome. And this was based on the data which came from a randomized phase 3 study. It's an international study called TELESTAR. And what they found, so telitrestat is a tryptophan hydroxylase inhibitor. That enzyme is critical in making serotonin. So the analogs, lanreotide and sandostatin, works by reducing the secretion of serotonin. This particular drug hits at the production of serotonin. Okay, so you just make less of the serotonin. So if that enzyme is inhibited, you don't make enough serotonin. If you don't have enough serotonin, you don't get carcinoid syndrome. That's the rationale. And what they found, that when you treated patients with 250 milligram telitrestat, 500 milligram telitrestat, you had significant reduction in 5-HIAA or serotonin levels. This also resulted in reduction in diarrhea. So patients in green and blue, they got varying doses of telitrestat versus placebo, and you can see the median decline in the stool output. And based on this data, FDA approved the use of telitrestat, and today this is the only FDA-approved drug in neuroendocrine tumors for carcinoid diarrhea control.
Is that used with sandostatin?
Yes. So it's important to understand that sandostatin or lanreotide is used as a frontline treatment for not only just tumor control, but if patient has functional syndrome, that means the tumor is also secreting serotonin to control that functional syndrome. But sometimes it's not adequate, or the tumor is just pumping too much of serotonin that the analog is not able to control all the symptoms, and you're still having diarrhea, breakthrough diarrhea. And then what else to be done? In that setting, we advocate use of telitrestat. So my advice is not to stop the analog, because you're going to lose the control, whatever you got from the analog. This is to supplement that. And this is not an anti-tumor drug. So this is more of a symptom management drug. So very safe and can be added to lanreotide or can be added to other systemic therapy if they were on, let's suppose, Afinitor, etc. Lastly, our third FDA approval in recent years was PRRT. Two of my mentors, Dr. Volin and Dr. Anthony, were involved in the trials, and they were both at Markey Cancer Center at that time. So NETTER-1 clinical trial is a phase 3 randomized clinical trial, international study, where they randomized patients between PRRT group, which is peptide receptor radiotherapy. It's a special type of radiation treatment. As I mentioned before, this drug is basically analog linked to a radiation molecule and is given through IV. The treatment's given every 2 months times 4 doses total. So in 8 months, you're done, and it's either works or it doesn't. And I've never seen, these graphs are called Kaplan-Meier curves. Basically, that tells us how, based on this one is a progression-free survival, how long was the disease stable. And I've never seen a Kaplan-Meier curve for any drug in field of oncology, like for any tumor type. This is stellar result. So the line in the green is progression-free survival for PRRT. At the time when they reported this trial, this was last year in New England Journal of Medicine, February, I think, they still hadn't reached the median PFS, right? Now it's estimated around 30, 35 months because we have a lot more follow-up. As compared to the control group, the PFS was less than a year. I think it's 9 months to be precise, 8.4 months. So right off the bat, the results were stellar. FDA approved this drug as of, I think, February 2018. And at present, there are probably more than 40 centers offering PRRT-based therapies in the country. So definitely a great addition to a great drug. We're like a decade behind Europeans, but we finally have it, okay? All right. And lastly, I'd like to mention a few things about where's the future of neuroendocrine oncology moving towards, okay? I think 3 years back, I was at ASCO, and then Vice President gave a brilliant talk about Moonshot, Cancer Moonshot program there. And the emphasis is to improve cancer treatments for all sorts of cancers, specifically also for rare tumors. Okay? And in that spirit, this is one of the reasons why I love neuroendocrine oncology, because I see a potential to grow and improve, because our treatment options still can be counted in one hand, as compared to breast cancer, where I have like 20 different types of treatments to offer, right? So we have a long way to go, but the opportunities and future looks very promising. One of the phase 1 studies we recently concluded, I'd be presenting data at next month's AACR in Atlanta. It's a novel combination of Afinitor plus a drug called fosbretabulin. It's a vascular disruptive agent in our gastroenteropancreatic neuroendocrine tumor patients. So the data looks promising, and we are hoping to move it further into phase 2 studies. Fortunately, I cannot discuss it because we are embargoed from disclosing the result before AACR. The other drugs currently in pipeline, and from what I've been reading, and the data looks promising, are cabozantinib. The PIs from Dr. Chang from Dana-Farber presented the phase 2 data, looked really good. The median PFS close to 20 months, radiological response is 18%. The drug works well, it's an oral pill, and we are currently evaluating in a phase 3 cabinet trial. And I anticipate in a few years from now, this would be the next FDA approval, the cabozantinib. Immunotherapy, how many of you all heard about immunotherapy? You all? Okay, good. We all have, right? A lot of television ads. So we are exploring immunotherapy, role of immunotherapy in neuroendocrine tumors. So far, there are some mixed results and mixed feelings about whether it works or not. It clearly works, I think, in high grades. Not so sure about the typical carcinoids, whether it works. But we'll see. There are currently 5 clinical trials evaluating role of immunotherapy. And next 1 year, we'll have a better answer. Then, just like Lutathera, which is the currently FDA-approved PRRT drug in the US, we have more competition coming up in this space where other pharmaceutical companies are investing and developing novel PRRT agents, so which is good news for our patients. The more choices, better it is. And then we have some novel antibody drug conjugates, DLL3 drug, rovalpituzumab, which is also currently in phase 1, phase 2 development for various rare tumors, including neuroendocrine tumors. So the space is definitely expanding. We also do a little bit of preclinical work. That's me spending some time with mice in the lab. So the clinical development is great, but we also need to find new targets, new drugs to to kind of and figure out if it works in neuroendocrine mouse model, preclinical model, and then bring it to clinics in patients who don't unfortunately have anything else to try if they progressed on Afinitor, PRRT, and other standard of care agents. So this is the most recent stuff I have, which I will be presenting to NCI soon. And I'm working with a novel DNA PK inhibitor with the radiation model. And you can see the amount of tumor shrinkage as compared to the placebo group. Looks very promising. So we are hoping to convert these preclinical findings into a tangible phase 1 clinical trial for our NET patients. So things look very exciting, very promising. I always like to end it in a positive note that way, okay? And I would like to thank Marianne and NCAN for inviting me, and I'd be happy to take any questions, please. Thank you.